let's let everybody in. Beautiful. I'm going to go ahead and admit everybody in the waiting room. Beautiful. Hopefully here. Welcome everyone. Happy Thursday. This is our community forum morning brought to you by the Pediatric AIDS Coalition. Just a few little housekeeping items. We're going to go right until 11 a.m. here at Los Angeles time. We're going to be recording this session for those who can't make it with us live. And then we are going to have a bit of an audience portion question at the end. So if you have questions for any of our wonderful panelists today, please DM your questions to the chat to either Megan or Katerina. They're both up here, you can see them, and they'll go ahead and field those questions towards the end. But we're very excited to have you all here today. Welcome, welcome. My name is Lexi. I am the cause director of the Pediatric AIDS Coalition here at UCLA, and we are just stoked to have everyone here. So let's go ahead and get started. Awesome. If we could get to the next slide, potentially. I'm just going to have each one of our panelists introduce themselves. We are super excited to have each one of you here today. We have Robin Smalley, co-founder of Mothers to Mothers, which is an incredible global organization. It's been around since 2001. And we'll have each of you be able to, expand on that because we definitely want to hear exactly what, has been going on with each of your organizations. Dr. Devorah Davey is an epidemiologist at UCLA who's now in Cape Town, South Africa. So we really appreciate you coming here despite all the time differences and everything. And Susie Mullen is the director and founder of Simply to Love, which has been putting together a clinic out in Kenya. So we're super excited to have you all here. I was hoping that we could go to the next slide because we have a little bit more in-depth information on each of the panelists. So Susie, if you could go ahead really quick and just tell some of our audience members who might not be familiar with Simply to Love, what your mission is, what you've been up to, just really briefly.
Okay, the reason I'm here with you guys is because of Katerina. She actually went to Kenya with me for a month this last year, and we got to know each other really well, and she thought maybe I would have some input on this because I work with orphan children. We work with an organization called Chosen Children of Promise. They have 350 sponsored orphan children in the Nairobi area, specifically Kawangware, a slum that's one of the bigger ones near Nairobi. And I have a group of 35 HIV positive kids. It's just like 10% of the total number of orphans that we have, that when I go over there, we always have an outing where we do counseling, talk about medication adherence, and they get to be themselves because in Kenya, you don't go around telling everybody you're HIV positive because there's a big stigma attached to it. So anyway, I don't think my expertise is the same as some of the other panelists. I'm more like the mom of a bunch of HIV positive kids. So yeah, that's kind of me. I'm a nurse.
Amazing. Thank you so much, Susie. I really appreciate it. And especially with, the global perspective that we're trying to get here today. Everyone's insight is super valuable. So thank you so much. The next person we want to introduce is Robin Smalley, co-founder of Mothers to Mothers. So Robin, if you could give us a little bit more for those who might not be familiar about the amazing work that you do.
Sure. Thanks so much for having me here. I'm really excited to have this conversation. Mothers to Mothers was born, so to speak, back in 2001. We just celebrated our 20th anniversary. And it was really created in response to a very weakened healthcare system in sub-Saharan Africa. And the fact that although medications for HIV were increasingly becoming available in sub-Saharan Africa, there was no uptake. And the reason is because there were so few doctors. Everything's run by nurses who are overwhelmed and overworked and overstressed. And so, and often didn't have the same language or culture as the clients that they were seeing. And so what would happen is a young woman would come in for her first prenatal visit, find out that she was HIV positive, and there would be nobody there to tell her that there was medical intervention available, nobody to tell her that she could prevent transmission of the virus to her unborn child and stay healthy to raise that child. And because of the stigma that you alluded to, Susie, that young woman would be afraid to disclose her status to her husband, to her mother, to anybody, and she would leave the clinic and go home to die, and her baby along with her. And that was happening over and over again, despite the millions of dollars being put into medical intervention. And so Mothers to Mothers is a very simple model that was created to address that very complex problem, where we take newly delivered mothers who are HIV positive, put them through a rigorous training, employ them, and that's key, by professionalizing them as what we call mentor mothers, so that when that young woman would come into her clinic for her first antenatal visit and find out she's positive, immediately a mentor mother is there to hold her hand, to put her arms around her, to say, you're not alone, I'm HIV positive too, my baby was born negative, we're going to get through this together. And she'd be brought into the Mothers to Mothers room located right there in the clinic, where she'd be surrounded by a sisterhood of women facing the same challenges and fears, and could get all the information and support that she needed to have a healthy child and to stay healthy herself. And so that was the original model, based in Cape Town. Since then, we have expanded to 10 sub-Saharan countries. We are, I believe, the largest intentional employer of HIV positive women globally. We have eliminated pediatric AIDS among our clients for the last 7 consecutive years, which I'm very excited about. And we've reached over 12 million women and children. So it's continuing to grow and have impact. And today, Mothers to Mothers addresses not just prevention of mother-to-child transmission, which is core to what we do, but a whole slew of reproductive, maternal, newborn, child, and adolescent health challenges. So I'll stop right there.
That's so amazing. Thank you so much for that, synopsis, Robin. And especially when we talk about creating an AIDS-free generation, that's exactly what PAC is all here for. And especially with, the Mentor Mother program that you have, I think that's really incredible. So we'll definitely be talking a lot about that more. But I want to also introduce our next panelist, Dr. Deborah Joseph Davey. If you could just talk to us a little bit about the work that you're doing right now, what's led you to it, your work in HIV prevention.
Yeah, thank you so much for the invitation, and hi everyone. I'm based in Cape Town, South Africa, but I'm a professor, an associate professor at UCLA in the Department of Medicine and the Department of Public Health and Epidemiology. I've been working here for 6 years now in South Africa, and my primary focus of my research is on HIV prevention and treatment in pregnant and breastfeeding women here. As I think Robin mentioned earlier, is we have the largest epidemic of HIV in the world, and the largest epidemic of infant transmission of HIV in the world. And so the way that we're addressing it is really working through primary prevention of infection. And so what we're doing is providing PrEP, so pre-exposure prophylaxis, which is an antiretroviral drug, to women who are HIV uninfected and may be at risk of acquiring HIV. And we know that about 1/3 of infections that happen in infants and children happen because of an incident infection, so a new infection in a pregnant woman. And so I'm running a clinical trial and some other studies on PrEP and pregnancy, and then also work a lot with sexually transmitted infections in pregnant women, couples, and other populations in South Africa. The way that I started is a long ways ago. I was a Peace Corps volunteer. So I was a Peace Corps volunteer in Gabon in Central Africa, and I arrived when I was in my 20s, having just graduated. And I was so passionate about the health of women. And I realized I was 22 years old, and women that I met there and I was friends with already had 3 children. And they didn't really have access to information about HIV, STIs, family planning. And from there, I pursued a degree in public health. I got my master's in public health and have been working in Africa really ever since, and working with women and children since that time. And so I'm really passionate about enabling equal access to information and to health products, and in this case, in biomedical products, including PrEP in pregnant women who are at a significantly increased risk of acquiring HIV and then transmitting it onto their infants, unfortunately. So yeah, we have an internship program here as well through UCLA if anyone is interested in learning more, but our real focus is on designing and evaluating epidemiologic studies to reduce the burden of HIV on families. Thank you.
Amazing. Thank you so much. And that's really awesome to, know that, coming out of college, this became a passion for you. I know we definitely have some people interested in the Peace Corps potentially in this call. And I eventually a little bit later, I'm going to ask how we can get involved just as UCLA students, as, young people who want to help in the HIV prevention world. But I was hoping I could follow up with a few of you on some things that you might have mentioned really quickly, especially for Dr. Davey and Robin, who's, your work spans a whole bunch of different countries and regions. So, having done some of that work around the world and knowing that you use, culturally relevant strategies to be able to connect with, mothers or people that are HIV positive, could you expand a little bit on what that looks like on the ground when you're doing some of these studies and working with folks in these different countries? And this could be for either one of our panelists.
I'm sorry, I'm not understanding the question. How you provide culturally relevant information, is that what you're asking?
Yeah. So like, given that you work in a bunch of different countries, how do you tailor that, on the ground to kind of be able to help most effectively in each place that you go?
Well, for us, I think the key has been, is always, we don't bring outsiders in. You won't see anyone who looks like me working in any of our country offices. We employ, everybody is from the local communities and has an understanding of local culture. And in fact, when we expand to another country, the first thing we do is try to adapt our core curriculum to what will be most effective there. And by doing that, we do a lot of listening and a lot of asking questions of mothers, of nurses, of people, who will be impacted by the program. We learned early on, nothing helps if you go in and you say, this is what you should do. If you go in and find out what is needed and try to help find ways that local people can get the job done, that's a lot more effective. I always remember a funny story when I was first got there and we were looking to work with a local implementing partner in Ethiopia at the time. And we gave the curriculum and we went there and met with everybody and said, basically, here's the program and this is what you do. And then got a question and we were talking about collecting data and it's like, well, that's great, but where do you get pencils? And I thought, okay, we definitely, have a culture gap here and we have to stop talking and start listening.
Yeah,
I agree. I think whenever we engage in an intervention or a program, we engage with the population that it will serve. And that's why I've always admired the Mothers to Mothers program, and I've learned a lot from them in terms of the mentorship model. But what we've tried to do is really speak to pregnant women, speak to young women, speak to healthcare providers, all the way up to the Department of Health at the highest levels, and really understand what are the barriers, what are the facilitators, or how best can we serve this population. So every intervention we come up with is aligned with the community and for the community. And it's all translated into the local languages. So we have programs in KwaZulu-Natal and all over. And so it's always in the local language and delivered by local staff that speak the language and our peers. Really, it's a peer model. So like Robin said, you're not going to see me in the clinic. So you're actually going to see people that live here, work here, and are young women delivering programs and delivering counseling and interventions for women.
I appreciate that. It's really good to know that, you're not just coming in there and telling people what they need, you're asking them, you're understanding, and, implementing these interventions in a really personal way. I'm curious too, what for each of you and your, various lines of work, were there some things that surprised you in terms of accessibility and amount of HIV resources to prevent uptake, and especially when it pertains to receptiveness to especially HIV positive mothers to be able to take treatment?
Susie, do you want to take that one?
Well, I don't know if okay, so I go to Kenya every year. I've been going since 2008. Sometimes I stay 4 months, sometimes I stay 1 month. I actually agree with what you guys were saying about not being able to come in from the outside and just say, do this and do that, because you have to develop a rapport. We have one nurse for 350 kids. That's why I'm building a medical clinic there, because I feel like that's a ridiculously overwhelming job for this one poor nurse who's in charge of all these kids. So yeah, we're almost done building a 4-story medical clinic in the middle of a slum called Kalangwari, and that's where we work from. That's our central location. But I think the people that I work with already know me now. I mean, so I used to be a Mzungu, now I'm Shosho, which means grandmother. I used to be a mom. I guess I'm getting old. So they actually hear me because they know I love them, and so it's great. Our communication is great. We're able to, I kept thinking, what is it that I do? I mean, like, as far as, because of the medical part of it, even though I'm a nurse, I don't do a ton. We do a medical camp and we see about 600 people in one day when I'm there, but I don't do a lot in their antiretroviral medications. I don't do anything like that. I'm not involved in their day-to-day, but I do talk about dispelling myths, like there's so many people who have told me that if men have sex with a virgin, that they're gonna cure their AIDS, cure their HIV, and just like all the things that they've been told that are just false, that we just have these big discussions about those things. But as far as actually treating them, I leave that to the doctors there. We actually have pretty good access to the medications we need through the government, so they just give them to our nurse at the center, and then we have a Leototo clinic that the kids go to for their checkups and to, see if they have, if there's, CD4 counts are higher or lower, their viral load is higher and lower, and treat them accordingly. So, just all those things. Medication adherence is a really big problem. They don't have responsible parents that give them their medicine, and they don't want to tell anybody that they have the medicine, so it's all secretive. So those are kind of some of the things I deal with.
I think peer modeling is also, there is a lot of reticence to taking medication. There's history of bad practice, throughout the continent where populations have been used as experiments. I mean, all kinds of things. And so there's very naturally, there can be a resistance. And I think, when a peer though looks healthy, I mean, we hear all the time patients can, they're afraid to disclose, or they don't accept their status. They just, it's too hard to accept. And it's because in their head, if you have HIV, it means you're dying, you're ugly, you're, all these, and they see mentor mothers who are healthy and beautiful and glowing and proud of themselves and putting food on the table and earning a living. And they're like, oh, that's the face of HIV. Oh, I can do that. If I take this, I can be like her. And that's what makes all the difference. And I think that's why so often it's much more effective at getting understanding around medical treatment when the education is given by a peer, as opposed to a doctor or a nurse who seems like is not of the same, does not face the same fears as women in villages and townships.
Right. I just feel like if they could just do the be able to, they don't tell the kids, and now I don't know if it's different in the countries that you all are working in, but in Kenya, in the area I'm working in, they've made a decision not to tell the kids about their status until they're a teenager. And that's a horrible idea, I think, and I've been trying to convince them to do it, but it's the stigma attached to it that they don't want their children to have to suffer. But at the same time, when they are just becoming, some of them are sexually active at 10.
Mhm.
And then they get told at 13 that they're HIV positive. They've already had, how many people have been infected already because of that? So I'm, that's another thing that we talk to them about is that, you didn't, you got HIV, it wasn't because of their, anything they did that they got HIV. They were born positive, so they have nothing to be ashamed of, and it's a really hard thing because they go behind the curtains to take their medicine. It's just sad. And we just try to work with that all the time.
Yeah, one thing we talk about a lot in PAC is dispelling the stigma, and especially knowing that with all the medical advancements that we've seen in the last few decades, HIV, like contracting HIV, being HIV positive, it's not a death sentence by any means. So having the access to, antiretrovirals, getting your viral load down is huge. If I could shift a little bit, I'm kind of gonna open it up to some like big discussion questions. And of course, the biggest, major news story of the day is COVID and what's going on with the pandemic that we're all living through for these past 2 years. So if I could just ask, really generally, how has the pandemic affected your work and preventing HIV worldwide?
Well, for us, mentor mothers early on in the pandemic were deemed as essential frontline healthcare workers by all of the ministries of health in all the countries where we operate. And that was really great because they were best placed, because they are from local communities, to be able to deliver the information about PPEs and about COVID. And it's as we all know, it's shifting sands. Every day is different information, and so they were there and able to do that. But at the same time, it was very frightening because all of our mentor mothers are immune compromised. They're all living with HIV. Most of them have had tuberculosis and other situations where they're compromised, and so they've been putting themselves out on the line every single day to be able to deliver, not just to fight HIV, but also to help their peers fight COVID. And we were in the position of, having to get equipment for them, and sort of competing with China and other countries to be able to supply, because none of that, masks and gloves, none of that was being supplied by the local government. So we had to do that to protect them. So that was one big way. The other was that early on we pivoted to a virtual mentor mother platform, which is something we've wanted to do for years, but it kept getting put on the back burner. This pushed it right to that front burner. And so we were able to virtually reach hundreds of thousands of more women than we could with the clinics closing down and with the transportation closing down. People couldn't get to the clinic. So we translated our curriculum into 29 different languages and made it free and readily available to families all over Africa, not even just our clients. And so that's really exciting because COVID's not going to go away and there's always going to be another pandemic. And so to have virtual capabilities where you can quickly push out information that is life-saving information, I think was a wonderful benefit for us.
Yeah, and I fully agree with what Robin has said, is that we had to adapt very quickly. All of our staff are also frontline healthcare workers, and pregnancy doesn't go away just because of COVID. What we did see, sadly, is that women were coming in later and later for their antenatal care and initiation, and even for birth, labor and delivery. And there were more and more labor and delivery even in urban Cape Town at home, because there was so much fear and stigma coming to the healthcare facility. I mean, I remember the first time coming to the healthcare facility where we work, and there's people out the door coughing with masks on, and it was terrifying. So I imagine being a pregnant woman coming to a clinic, being pregnant or with a baby. So a lot of our women that we were following in our cohort studies stopped coming in. Or they came in later, or we had to do home visits, and we had to do a lot of things like health strategies, where reach them on the phone, do interviews on the phone, do interviews outside. we adapted pretty quickly to be able to see them, because pregnancy is only a short period of your life. So we can't say, come back in 6 months when COVID, when we thought that COVID would go away. And so we developed a differentiated models of care, which enabled us to go into the community, go into the homes, and talk to people on the telephone, whereas before we were all clinic-based. And so it enabled us to think about different innovative ways of reaching people. But that said, I mean, with Omicron here last month, I think half of my staff were infected, and a lot of my staff are HIV infected as well, like Robin was saying. So we've had a lot of battles with being exposed generally, even with PPEs and all of that. Nothing's perfect. And so it's been a scary time. And it's been challenging for us working in urban areas of South Africa.
For me, all of the things that you do to like the masking and the social distancing and all that is pretty much like impossible where I am. I mean, like if you live in a house that's 10 by 10 and you're all sleeping in that same room and people are coming in and out, I mean, like and then you look, I mean, our school, the kids, their masks are hanging down over here and all the snot's coming out of their nose on top of their mask. I mean, it's like, it's like all of those kind of things are kind of hard to deal with. But I don't know, I think it's interesting. I want to hear you guys because you have more of a medical expertise probably than I, but I think it's interesting because when I look at the stats, I always look at the stats every day for Kenya because I care about my friends over there, and it always seems like, and I know testing isn't as, they can't get to it as easily, but I mean, like I just looked up the highest new cases for today. It said in the whole country of Kenya, it goes 1,437. And I'm like, that's really a low number. So what's your take on all that?
Well,
I don't think they're testing. I don't think they're testing it very much in most of the countries where we're working. I don't know, Robin, what your experience is, but I think there's very limited testing going on, and it's expensive. I know in South Africa it's expensive to test. So I know the US just got free test kits. That would be amazing in South Africa. But my kids just started school. There's no testing going on. I think testing is a very Northern Hemisphere kind of European US thing. We get tested everywhere you go here. And I know UCLA, you have to get tested like 5 times to step on campus. So no one's really testing here, unfortunately.
Well,
yeah, I don't think we can trust the data.
I was going to say we have, out of our 350 kids, we have not lost any, and we've lost one mom. So I just feel something, there's something about Africa we need to figure out over here because
everybody is speculating. I mean, from what I read, it's just speculation. Is it because we don't have a really aging population in Africa? I think is a big thing. We don't have a lot of overweight people in Africa. All of these things that contribute to risk in a strange paradoxical sense don't necessarily apply to Africa. And they're finding, ARVs can have some kind of prophylactic effect on protection. So, yeah, all those things play into it, but I don't think anybody really knows. But certainly, I also don't think we're getting, we can trust the data because of the lack of tests.
It's interesting.
I know that has definitely been a challenge. And I think what, like you were saying, Robin, potentially there can be some antiretrovirals that can be also applied to COVID, or, maybe work on some similar level. I'm curious from your perspective, or from everyone's perspective, if there's any lessons that you think from the HIV and AIDS crisis that can be applied to, preventing the spread of the pandemic that we know as COVID.
Well, certainly, overcoming fear and stigma, is really applicable to both. The importance of relying on facts and science as opposed to rumors and misinformation is certainly, important for dealing with both of these epidemics, both of these pandemics. I also think, people are realizing the importance of community health workers for both HIV and COVID. That when push comes to shove, especially in rural areas, especially in poor areas, we have to find better ways to support our frontline people.
Definitely agree. I think we also realize the importance of, global inequity. And HIV, it was very acute. I think when Robin and her team started in South Africa, there was no access to antiretrovirals. And we're seeing the same thing right now in Africa, where fewer than 3% of the population is vaccinated, and everyone else is going on like their fourth vaccine already in the US and then in Europe. So we can't even, like I was talking about before, is we're only getting boosted now, whereas we should have gotten boosted last year before Omicron. And so inequity is still acute. We don't have access to the treatments, all of these new treatments that are coming out that are proving to prolong people's lives. We don't have access to in Africa. We're fighting for access to even manufacture vaccines now in South Africa. In South Africa, we have amazing capacity here to manufacture vaccines, but even to get the licenses and the authorization to manufacture vaccines. And it's the same thing with ARVs. We fought for years to have generic antiretrovirals, and finally we have access to that, and it's made, cut the cost in half, or even more than half. It's like a tenth of the cost that it was a few years ago when we couldn't get generics. So the inequity in terms of addressing the pandemic and preventing morbidity and mortality persists, unfortunately, and we realize that now. And then also the need for a really strong governmental approach. I think we've addressed it pretty well in South Africa, I think, because the government took the lead and they recognized that it was a problem in the beginning, and that it was affecting really some of the poorest communities in South Africa, at least with the first few waves. And the government took it up. In South Africa, we have a big problem of denialism. I think a lot of our presidents in the beginning denied that the HIV was a problem, or that HIV caused AIDS, or that garlic and lemon juice could cure it. And so it's really important to have correct information given by at all levels. And unfortunately, now we have total misinformation about both COVID and HIV. And if you go on there, you can find misinformation about COVID especially, but also HIV. Like Susie was talking about, myths about how you cure HIV, and all of that still persists and is still perpetuated on social media. So there's a lot of parallels. I mean, the only thing that's different is that HIV is primarily, at least here, is sexually transmitted, and that COVID is just is an airborne disease. So that's the big key difference. But there's still stigma. I still have know people that won't admit that they had COVID, which I think is crazy. So there's a lot of parallels that we can find with the pandemics.
Thank you for outlining that for us. I think that makes a lot of sense. I'm also really curious to talk to you all about, when it comes to the parallels of HIV and COVID, particularly when it comes to new developments in your line of work, potentially, like we really touched on very briefly before everybody joined, a potential vaccine or treatment for HIV that could be completely novel. So are there any new developments, I guess, in your work as you see it that excite you for the years ahead?
Well, I think the push for universal health coverage is something that I think hopefully is there's a big push going forward. We talk about it a lot in terms of equalizing the playing field, and health is a human right. I think because rich people and poor people get COVID, and you're not immune, because we all share the air we breathe, and the world is increasingly becoming a smaller place. People who have power are being impacted by this just as much as people in rural communities. The importance of access to care and treatment is foremost in people's minds, and I think there's a lot of activism that can be mobilized around that.
I agree. And from my perspective, I work a lot with PrEP. And now we have longer acting methods, including cabotegravir. One of the big problems about PrEP in terms of prevention of HIV is that you take it every day like a birth control pill. And it's challenging. And so adherence, persistence, continuation, all of those have really been challenged, especially for young women. I think that cabotegravir, other long-acting methods, there's a long-acting pill that we're evaluating right now, and other methods that might simplify taking this prophylaxis to prevent HIV. So I'm really excited about that, and excited about making it available, especially in the context of high HIV incidence in South Africa or Southern Africa.
I'm also really excited about, we are actually working to bring the Metromother model here to the US. One thing that COVID has certainly done is highlight the vast healthcare inequities facing women and children of color in this country, especially in the South. And so for the first time, I hope this year, we will be able to start rolling out a pilot program here in the Deep South to sort of bring, our work around empowerment and empowering local women to guide the healthcare of their families and communities to this country. And I don't know that that would have been possible had COVID not shown the vast racial inequities in healthcare here.
I actually have another job. I'm the clinical nurse manager at a pregnancy center. So I do options counseling and ultrasounds, pregnancy tests, and we help moms who can't afford baby supplies and all that kind of stuff. But I get that opportunity to mentor. They mentor each other. I mean, when they come into the office, the moms that come in to get their monthly supplies and everything for their babies, they converse with each other, and I think it's really helpful for them to know that they're not the ones that are all alone trying to raise their babies all alone. And I think it applies also in Kenya as well, that community is a huge thing. We have a moms group, it's called the Fideli group, and they meet once a week and share something to eat, and then the nurse gives them information, and they give them also things like supplements. They take these weird supplements like stinging nettle and amaranth flower. I don't know if either of you have heard where you're working those things, but they take those because I guess they boost your immune system. And I just think community is huge when it comes to all of those things, teaching, when it comes to dispelling fear and giving people confidence. It's super important.
Yeah, definitely important to have, community, people in your corner, especially when you're talking about, mothers that can relate to whatever you're going through when you're raising a child and not trying to pass on HIV. I know really quickly, Dr. Davey talked about, South Africa's vaccine capacity. And I, knowing some of the really turbulent history, if you could put it lightly, in terms of HIV and producing antiretrovirals and getting those out back in the 80s and 90s. If you could, obviously we can't predict the future, but if there were to be some exciting, new development in terms of HIV prevention and care, are there challenges that you foresee in, getting them out to the people that you need to take care of? Or how do you see that changing from the challenges that we face in prior decades?
Yeah, unfortunately, it's still pretty slow. The regulatory approvals, like the equivalent of the FDA here, is very slow at approving, and then the Department of Health. So all of the procedures that have to go through to become standard of care is still quite challenging. I know here, I think Kenya as well. I think Kenya is even more advanced than South Africa just because of the politics here. So even if something is approved in a clinical trial, it would probably take a year or so to get approved. and then to be part of the standard of care. And then you have to train providers, and you have to make sure it's accessible in the pharmacies and that people use it. And that's why I think the Mentor Mothers model works really well, because they're able to inform people about the availability of the new medication or prophylaxis. But in general, it takes, I would say, a few years to actually become mainstream and get part of the standard of care in the clinics, just because of the various regulatory and training and procedural barriers. I'm not quite sure why Kenya is more advanced, but it seems like Kenya approves new drugs and new treatments and quicker than in South Africa, unfortunately. And we have, our epidemic is a lot worse here.
I have a feeling that's because I don't know if it's like that in South Africa, but they really emulate Western, what Westerners do. They want to be like America. I don't know if they do anymore, but they used to really want to be like Americans, So I think anything that we do, they grasp onto really quickly there.
I think
and research, they follow the research as well. From what I've seen, they read the research and they implement it. Whereas in South Africa, they want to do whatever they did in Kenya or did in the US or whatever, they want to repeat it here first. They have to make it South African first.
And it's one thing, it's like, we always say good medicine does not equal good medical care. You can have great medicine, but if you have 4.2 million, a shortage of over 4.2 million health workers, so often treatments, especially when they're new, they have to be administered by doctors. And like a country like Mozambique, as I was on the phone this morning with our country director in Mozambique, and there's 3 doctors for every 100,000 people. That's how on earth are 3 doctors going to administer drugs to 100,000 people? So it's a supply chain problem. It's not just discovering a cure or discovering a new vaccine. It's a problem all the way through getting it down the line.
I know when I was in Kenya in 2014, I had a little girl, actually the only little girl that we ever lost to, well, it wasn't AIDS specifically, but she got TB because of her HIV, and then she ended up with a pituitary tumor. But every year I'd go back there and I'd see her in worse and worse shape. And so I decided I'm going to be here for 4 months. I'm going to try to get a neurologist. I'm going to try to get all the things that she needed. But as soon as I left and came back, everything was set up. We had the neurosurgeon, the neurologist, everything was set up. As soon as I went back, the ball got dropped. And I think that's part of it too, is just there's the urgency, there's just not the urgency with things like this. They're so used to living with illness and those things, they just don't, do anything about it. So I went back in the end of November and she died on like the 26th of December. I just it was so brokenhearted because I had put so much into it. She's kind of our poster child because she's the only one we've ever lost. But the urgency is just not there. I don't know why. I have a picture of her if you want to see. I brought it.
Oh,
Her name was Vanessa. She was a sweetheart.
Oh, it's very sweet. You have a lot of love for those kids. It's amazing.
Yeah, that must be incredibly hard to, lose any of one of your kids or, anybody that you're working with. But, it must be gratifying to know that you're working actively to fight against any other unnecessary losses. I'm curious for you all as well. Having worked in these spaces for, however long, implementing incredible mentorship strategies and research, what projects or outcomes are you the most proud of in your work in HIV prevention? Or are there any particular projects you can speak to that you were excited about?
I'm really proud that when we started, women were seen as the volunteer workforce of Africa. The notion of paying an HIV positive woman was anathema. I mean, people thought we were crazy. They said it's not sustainable. You can't do it. They're not responsible enough. They have too many, everything. And we stuck with that. And we've employed over 11,000 women now who would have been considered unemployable. And I'm proud of that. But even more so, I'm proud that I think they, through how incredible mentor mothers are, how courageous they are, how professional they are, how much they help and model, they've really changed how HIV is often seen in their communities. And certainly they've changed how women are viewed in their communities. And nobody says anything now about paying them. People assume that they should be paid and that they have value. And that's not something that I saw 20 years ago.
I would be proud of that too. I remember that fight. I've been here for a while and in Mozambique as well. And I remember the fight to pay community health workers and to even pay HIV counselors.
Mm-hmm.
Remember, back in the day, like they expected people just to volunteer and, test other people and to do all of the counseling without getting any pay. And now it's become part of the standard, I think, in most countries, I think in all countries where we work. So that's an amazing shift. For me, I'm working to make PrEP available for pregnant women. So we've changed the policy here. We've changed the policy in a couple of different countries, and I'm leading a research group in a few different countries, really pushing making PrEP part of the standard of care, like they have it in Kenya, so that everyone that's HIV uninfected and getting pregnant or already pregnant and breastfeeding can access it. And we're pushing. I think that it's more and more available now than it was, a few years ago. And so that's good. And the guidelines just recently changed in South Africa to make it part of the standard of care. So we don't have to beg, borrow, and steal now for medication. So the medication's available and the providers have been trained. So that's really where I'd like to work with the Mothers to Mothers model is to reach both HIV negative women and HIV positive women. I think that's kind of the next step, is to have a sero-neutral approach where you approach all pregnant women in the same vein and realize that they're all really at risk of HIV. So yeah, that's the thing I'm proudest of. Thank you for that.
I haven't really done anything like that. I was going to say I'm building the medical clinic. I guess that's the thing that I'm most proud of, because they'll have more access to healthcare. But as far as specifically for HIV, just education is probably what I'm most proud of.
That clinic is huge. It's going to change their lives and change the way that they see their care. So don't minimize it. I think it's going to change the dynamic of that community.
And every child that you love in the way that you do is going to change that child's life. And you can't even imagine how much further that influence is going to go. So I agree. I never know what you're doing, Susie.
Oh, thank you.
I definitely agree. Never ever minimize that, but also it's amazing to think about how much of a tangible impact you've had on, countless people's lives, not just the people you directly talk to, but, the children they go on to have and the people they end up working with, and how, the labor standards that you were talking about, Robin, like that extends, far beyond just, healthcare work. So I think that's really amazing. I know we're kind of like nearing the end a little bit here. So I'm curious, I know there may be some students listening who might be interested in some sort of international health promotion work, very similar to what you all do. But besides just working with you, are there qualities they should look for in organizations that will allow them to have the most impact? And what do you think they should look for?
That's a really tough question. And I get asked it in school context all the time. And I wish I could come up with a better answer, because frankly, I think it's very, very hard for young people from the US to break into working in the field often, because and for good reason, because I think most organizations now are trying to have local are really trying to build local capacity and use local people. And I think that's super important, but it does make it more difficult for young people to go over if that's what you're talking about, other than services like Peace Corps and all of that, which are geared for that. It is becoming increasingly difficult. It's becoming increasingly difficult to get visas for anybody, much less a student who can't prove that they have skills that nobody else in the country has, which is basically what you have to do to get a visa these days. I don't know, do either of the two of you have any ideas of what?
I've brought a team over every year of just whoever wants to come, really. They didn't even have to be medical. In fact, that's how Kat and I know each other, because I'm in a relationship, working relationship with her mom.
Mhm.
And I actually had never met her before. And so she came over with me, and basically it was just her and I, because the people who were going to come with me all got scared because there was a COVID spike right when we were coming. So they were afraid to come. But yeah, every year I take, 6 or 7 people over there, and we teach, we teach all these basic things, like you don't have to be an expert. And like, hand washing, stuff like that, like, why it's important not to be touching each other's blood. I mean, they've got these little, I always think of this when they've got these little pencil sharpeners where the plastic part's gone. So all they have is the little middle of it with the razor blade, constantly cutting themselves. And then they just don't realize that they could spread HIV by, blood to blood like that. And I take them, and then we show them part of the country. I took Kat to Mombasa, saw the beach, doing safari, to see all the different things that are the beauties of the country, but also the challenges of living there. And I feel like it's been very successful as far as people continuing to support after they've gone. So I think seeing the situation really has an impact, not only on young people, even on older people, So you're all
For me, in an academic setting at UCLA, we take interns all the time, and it's a short internship, I think 3 months, but I also take PhD students for longer, and they can usually get a student visa, so it's different than a work visa as a student, and then they can still get paid as a student through UCLA and those sorts of things. So from my perspective, it's not impossible, but we usually pick only a few, because we don't want to overwhelm the health facility with a bunch of students from foreign students. What I look for, I think that Peace Corps would change my life. I think spending 2 years and with a community and developing empathy and understanding where that community comes from really changed how I work and who I am. So definitely recommend the Peace Corps if you can do it. I think Peace Corps is running again. I think they closed down a while for COVID, but I think they're up and running again. So do Peace Corps and speak a language. If you can speak a foreign language, I think in Swahili, you don't need to know Swahili in Kenya. English is very much common here, but I think learning the local dialect is really important. So wherever you are, try to speak at least some of the language and study a language. And then just be flexible. I think some students don't do well when they come here, or have a really hard sense of like, I need to do this. I need to sit at a desk where it's air conditioned and publish a paper. And it's not like that in the field. It's not going to be air conditioned. It's going to be dirty, and it's going to be, and it's going to be, things will be changing. And so be flexible. And so those are the things that I would say to make a successful intern in my perspective.
Those are such good tips. I also thought Global Health Corps has a fabulous program that I don't know if you're familiar, but they pair up young people here with somebody from the developing world and put them in health situations for, I think it's a minimum of a year. I think it's a year to 2 years, and they're doing some great stuff as well.
I agree.
But my biggest regret is not doing Peace Corps. I always regretted not doing Peace Corps. So
you can still do it.
I know.
I love hearing how we can get involved. I think that's awesome, especially as young people that are, wanting to get out there and change things. It's awesome to hear. Maybe we'll have to ask for a link from you, Dr. Davey, about your internship program in case any of our PAC members are interested. Same thing goes with, potentially going to Kenya. That really sounds amazing. I do have a real quick audience question as well. I know we only have a couple minutes left, so we'll only be able to take a couple. But one of the questions that we received was, why have you chosen to focus your efforts in the countries and regions that you do, kind of generally? I know we talked a little bit about, the high prevalence of HIV positive people, but if you could speak a little bit on that.
Well, for us, it was easy. I mean, our mission from the beginning was to end pediatric AIDS. And so to end pediatric AIDS, you have to be in Africa. And so, that was sort of a no-brainer to start in South Africa. And then since then, we've, expanded really based on need. So, we are invited generally by the ministries of health because they have a terrible need and so many children are being infected needlessly. And so it's not that wasn't a hard choice. It was a no-brainer.
For me, it was because I had done medical missions and just, I mean, I'm a Christian, I go to church and I've gone on mission trips with my church to all different countries. I went to Thailand and Romania and I kept thinking, it's really great to come over and help for a few weeks, but I didn't have any lasting relationships because of that. So I just decided in 2008 that I wasn't going to keep going to all different places. I was going to concentrate all my efforts to one place. And so that's, it's been finding a home away from home for me. I feel just as at home in Nairobi as I do here. So anyway, that's why I chose Kenya.
For me, I was working on HIV treatment prevention in Los Angeles while I was studying there. I also got my PhD at UCLA. I don't know if I mentioned that. So I was in UCLA before we moved here. And I just didn't feel like I could make an impact on it. I felt like it was a smaller epidemic and there's a lot of people focused on it. And I married a South African. So because my family is South African, it made it easier for us to move here. And I love Cape Town. If you ever come to Cape Town, like Robin said, it's her second home. We love it here. It's a beautiful place and it's the people are wonderful and the work is necessary here. Unfortunately, the epidemic is still raging. So it kind of hit all of those criteria for me to be a nice place to live and also have a lot of need that I feel like I could address as an epidemiologist.
I love all the various reasons. There's no one reason to come. Of course, there's a common thread, but I like, whether it's the church, whether it's, marriage and family. It's awesome that you've all, been able to come and stay wherever you stayed. And I think that kind of brings us to our hour here. But to our panelists, I really can't thank you enough for being here and sharing all of your insight and, words of wisdom for us young people that are in the chat. Thank you so much for your time. It's been really great to speak with each of you. We may have one more audience question if you have the capacity to stay. Robin, I know you had to go.
I do have to go. I'm so sorry, but thank you very, very much for this opportunity. And I hope everyone got something out of it.
It's nice to meet you.
Absolutely.
Thanks, Robin. Take care.
Take care.
Okay, bye-bye.
Thank you so much, Robin. And then I think real quick, Sam, did you have a question potentially? If you're able to unmute.
Yeah, I do, but I don't want to, keep anybody for too long. But I guess my question was, where does like the idea of like independence or kind of like, is the ultimate goal of mentorship groups or like mentorship based groups in developing countries like Africa, eventual self-sufficiency? Like, is the ultimate goal that your groups will not be needed? Or I guess, where does that kind of like idea fit into the framework? And I apologize if that question is not cohesive.
No, it's totally cohesive, Sam. I think it was more for Robin, but I know Robin's model pretty well because I've worked with them. And I think, I don't know what she would say, but I think that she would say, yes, definitely they want to work themselves out of a job. And what they would like to do is have the governments and the departments of health hire these women directly. Is to realize the importance of hiring community health workers and peer mentors, part of the HIV program or part of the health program, so that we don't have to get, external funding. I think that's really essential. So there is a plan, I know, in South Africa that's just going to cost billions of dollars. So it's kind of one step at a time, and the advocacy and demonstrating the value of the mentors and fulfilling a role that healthcare workers can't do. So really working with nurses and doctors wherever they can and making it an essential service that the government will pay for. I think that's what she might say.
Susie, do you have any thoughts on that question?
I honestly feel like it was kind of more addressed to Robin. I think when you talk about being self-sufficient, I don't think that where I am visiting in Kenya, they live together. I mean, like I think the best thing is to continue to have mentors. I think even for us here in America, it's important to have people that you can go to and talk to and not to be, I think they're self-sufficient. I just think that they need each other probably even more than we do, and I think that's a wonderful thing, and it would continue. And that doesn't take away from their self-sufficiency. I think it actually makes it more, like they feel more powerful because they know that they have an army of people behind them that support them. And I don't know if I'm getting the question right, but that's what I was hearing.
That's perfect. And with that, I think that wraps up all the time we have. But yeah, thank you so much, Susie and Dr. Davey, for sticking around for a couple extra minutes. And for Kat and Megan for monitoring the chat. It's been really, really wonderful to have you here. Thank you so much for doing everything that you do.
Thank you for organizing, and Susie, nice to meet you too. Take care, everyone.
Bye.
Thank you so much. Have a good one.
Hey guys.
Thank you too. Bye-bye.